To this now, young gay and bisexual men face a disproportionate burden of sexual health conditions compared with heterosexual men. This disparity is due to factors such as criminalisation and stigmatization of same-sex practices. Now, Kenyan-based researcher Samuel Mwaniki has studied and explored the attitudes and perspectives of healthcare providers when having to provide services to this grouping. And he joins us virtually from Nairobi in Kenya. Samuel, thank you so much for your time. And I know this is a piece that you've written in conjunction with other researchers as well. So we do appreciate you taking the time to tell us more about your findings, just to lay the foundation for discussion. Give us a perspective of what the law in Kenya says about the provision of health services to all groupings in the population, and what was some of the experiences that you would have heard of that led you and your team to believe that this was something that needed to be studied further.
Thank you, Marcel, for having me. And let me start by congratulating you and the whole of South Africa for winning the recently concluded World Cup.
Thank you.
And now to the study. The WHO Constitution of 1946 envisages the right to the highest sustainable standard of healthcare as a universal human right. And this right is further enshrined in the Kenyan Constitution of 2010 under Article 43. We know that the Penal Code does criminalize same-sex practices, but the Supreme Court recently did affirm the rights of sexual and gender minority people to associate, but still we have a long way to go because the criminalization of same-sex practices then hinders the access to healthcare by these sexual and gender minority people. So our prior work had demonstrated that young gay and bisexual men have a high burden of HIV as well as STIs compared to the young Kenyan men or in the general population. So we did find out that the prevalence of HIV, for instance, was 13 times higher among the young gay and bisexual men as compared to the Kenyan men of the same age bracket. And we tested for 5 curable sexual transmitted infections, and we found that more than half of these participants tested for at least positive for at least one of the 5 STIs. So what we did, we went further and spoke to a small group of these young men, and we spoke to them in in-depth interviews. And what we found out was that they do experience stigma, discrimination, as well as prejudices and microaggressions when they seek healthcare services. So for us to obtain a wholesome picture, having established a disproportionate high burden of these health conditions, and having spoken to a subgroup that spoke of stigma and discrimination, we wanted to now speak to the healthcare providers to obtain their perspectives on attitudes toward care for young gay and bisexual men. And what we did find is that despite the healthcare providers being cognizant of their duty to provide care, they had somewhat stigmatizing attitudes or unsupportive attitudes that hindered their ability to be able to provide this care. So this wholesome understanding then can help us to develop interventions that can help to reduce stigma in the healthcare setting, that will enable the people who are in most need of health services to be able to access these services.
Talk to me about some of the feedback that you got. You focused on tertiary academic institution-based healthcare providers, and you found that in talking to them as part of your research that what they call their personal values, their societal norms and religious beliefs did have an impact on their view of the person that they were having to give healthcare services to. But many of them said they continued to do their work despite what their personal views are. And it makes one wonder what the experience is of the patient receiving that help, because they might be getting medical care, but they probably don't feel very comfortable receiving it.
Yes, you're correct, because we actually came to the healthcare providers out of the experiences of the patient. And although the healthcare providers feel that they do not express stigma and discrimination, but there are subtle ways of expressing stigma and discrimination, and these are referred to as microaggressions. For example, a provider might not discriminate outrightly against a sexual and gender minority person, but there are things that they might do or things they might say or facial expressions that make this person feel uncomfortable. One of the experiences we had from one of the patients was that when they went to the healthcare provider and they had an anal sexual transmitted infection, after the provider probed and then eventually the patient said that they had sex with another man, then the provider did leave the room, went and called other providers. So the providers would stream in one by one and taking a look at the patient and going away. Really, that's not even a microaggression, it's a macroaggression. And then it is such experiences like every day saying that people speak about things that people talk about that make the patients feel that this is not the right environment for me. And then that leads to postponing seeking care when they need care or in care. And this could be seen from the work that we did. You can imagine close to 60% tested for at least positive for at least one of the 5 STLs that we tested for, which means that they had an active disease, but they were not seeking care for it.
What impact does the view of the community around that healthcare institution, I think especially of our primary healthcare institutions like clinics that are very much embedded inside communities where they are normally set up, what impact does the views and the stigmas held up in those communities have also on these young men seeking the healthcare that they need from the institutions that are actually on their doorstep?
Do you mean the institutions in the tertiary academic institutions or the healthcare?
That as well as primary healthcare. I know it's probably outside of the gambit of your study, but I'm interested in knowing how much of an impact the views of communities that are held has on how comfortable these young men in the gay community feel when they are seen to be going to a clinic or to a healthcare institution to seek the health services that they have a right to.
So again, going back to our previous work with the young gay men themselves, the experiences they narrated to us included both the experiences in the healthcare settings, as in the university settings, as well as in the community settings. And you find that they did say that in the public sector, that's where a lot of the stigma and discrimination happens. More or less so in the private sector, and even far less in the community-based organization and non-governmental based organization health clinics, which provide services that are friendly to them. And because these community-based or non-governmental organization-based clinics are few and far in between, they cannot be able to meet the demand. But generally, you find that the young gay and bisexual men do avoid going to the places where they feel that they are going to experience stigma. And that's what leads to avoiding care, because then the facilities, which are community-based and provide services, friendly services to them, are very few and they cannot be able to meet the demand for everyone. And that's why we did this work to see if there is a chance for us at the tertiary institution level to be able to probably train healthcare providers and sensitize them on how to identify the needs of sexual and gender minority people, and not just to identify the needs, but to be able to competently respond to these healthcare needs. But as rightly as you say, there's a big impact in terms of the views of the community, which leads to the young people either avoiding care completely or delaying to seek care when they need to seek care.
Some of the views and stories that you've brought across are quite similar to some that we often hear in South Africa as well, where we too struggle with stigma and the healthcare provided to those within the gay community. I'm wondering if this is something that perhaps should be looked at a regional level, at a continental level. Have you been able to exchange your findings with academics in other parts of the continent, and have you found any golden thread amongst the work that you've all been doing?
Oh, thank you very much for that question. I think it's important to note, for example, South Africa has got one of the most liberal law as far as sexual and gender minority people are concerned, but you cannot legislate against stigma and discrimination. People choose to live in a particular way. I have had an opportunity to share this work, especially this week. I was in a workshop with several people from different parts of the continent, including Nigeria, Ghana, Uganda, Tanzania, South Africa, and we were not specifically speaking about this topic, but then the topic comes up every time because now we are discussing as a research community the kind of different work that we are doing. And as rightly you say, there's need now for a regional intervention to be able to address this stigma. And most of my work was actually inspired by work that was done in South Africa. And as you can see from my work, my co-authors, Professor Tesla Palani of the University of the Witwatersrand, was the big supervisor of the project. And we're exploring ways of seeing if we can be able to work together to address this stigma that is quite pervasive. And it cuts across the whole region in Africa. It doesn't matter in which country you are, whether you're in South Africa, whether you're in Kenya, whether you're in Nigeria, only that it is expressed at different levels. But still work needs to be done.
Okay, we're going to leave it there. Thank you so much for your time and your insights this evening. That's researcher Samuel Mwaniki speaking to us from Nairobi in Kenya.